Hello, everyone. As probably you've seen, we've had some issues with Zoom this morning, but I think that we are back up and running and everything should be working for the webinar smoothly past this point in time. My name is Liz Gilton. I'm an Associate Director of Research at the Kathleen Babineau Blanco Public Policy Center and head of the implementation team for the Whole Health Louisiana program. We are excited to welcome you to our 8th Lunch and Learn for Whole Health Louisiana. WHL is a collaborative effort led by the Louisiana Department of Health as the public sector anchor and funder for the Whole Health Louisiana initiative. And the Blanco Center leads the plan's implementation and evaluation. If you're unfamiliar with what Whole Health Louisiana is, Whole Health Louisiana is the state's cross-sector initiative intended to systematically address, mitigate, and prevent childhood adversity within our systems of care and support. WHL has 4 priority areas and goals: collaboration, awareness, workforce, and prevention and healing. With these priorities in mind, WHL's vision is to build a state where children and families and community members across Louisiana are healthy and thriving, regardless of who they are or where they live. I'm going to turn things over to Quinn, who's going to be our moderator for today's session, and she'll introduce our speaker today, who we are thrilled to have join us. Thank you so much, Dr. Gillispie-Bell. So Quinn, please take it away, and Brooklyn, maybe move the spotlights around a little bit so we can see Quinn too. Thank you.
Okay. Hi, everyone. I'm Quinn. I'm a research associate here at the Blanco Center, and I'm a coordinator for the Whole Health Louisiana project. I will be moderating today's webinar and all of the future webinars, along with my colleagues here at the Blanco Center. So as a part of the Whole Health Louisiana initiative, we are holding a variety of different activities meant to raise awareness and deepen conversation about trauma-informed care practices. Our virtual Lunch and Learn series touches on the workforce priority area of the WHL plan and features presentations from industry professionals and subject matter experts. We have a webinar planned for one Thursday for each month for the remainder of this year, and each webinar will touch on various topics related to the goals and objectives of Whole Health Louisiana. Our planned webinars are listed on the Eventbrite page that you all use to register for today's event. And before I introduce our speaker for today, I want to first mention our ASL interpreter for today is Lisa Gill. You should see her pinned to view the interpretation throughout today's presentation. So I'm now going to go ahead and introduce our speaker for today's webinar. We have Dr. Veronica Gillispie-Bell, who is a board-certified obstetrician and gynecologist and an associate professor at Ochsner Health in New Orleans. She is a senior site lead and section head of women's services at Ochsner Kenner, the Director of Quality for Women's Services across the Ochsner Health System, and the Medical Director of the Minimally Invasive Center for Treatment of the Uterine Fibroids. She earned her medical degree from Meharry Medical College, completed her residency at Ochsner Health, and holds a Master's of Applied Science in Patient Safety and Healthcare Quality from Johns Hopkins Bloomberg School of Public Health. She also holds a certification in diversity and inclusion from Cornell University. As medical director of the Louisiana Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review for the Louisiana Department of Health, she is a leading force in addressing maternal health disparities. Her work focuses on improving birth outcomes and eliminating racial disparities in maternal health across the state. She has also testified before Congress, led congressional briefings, and was an invited speaker at the White House Maternal Health Day of Action, where she advocated for policy improvements in maternal care and outcomes. So please welcome our speaker for today, Dr. Veronica Gillispie-Bell. Take it away.
Thank you so much for that introduction, Quinn. Thank you all for having me here today. Excited to be with y'all, especially because this is Black Maternal Health Week. So excited to share with you some discussions about addressing the drivers of structural inequities and its impact on maternal health outcomes. Just as a disclaimer, the views and the information that are expressed by me today should not be construed as legal advice or determinations of the Louisiana Department of Health or Ochsner, the places where I have positions. These are my views that I'm presenting today. And then I also want to give a trigger warning that this presentation is going to touch on some experiences of racial and medical trauma, and so it can cause distress to those who have been impacted by those experiences. And this presentation is intended to align with a trauma-informed approach by recognizing the prevalence and impact of trauma resulting from structural inequities in healthcare and policy while resisting re-traumatization. And so I just want to make sure to give that trigger warning. So for our objectives today, we're going to identify disparities in maternal health, discuss implicit bias, as well as structural inequities at the root of those disparities, and then talk about a pathway for change. So as we think about structural inequities and social determinants of health, in 1906, so a very long time ago, W.E.B. Du Bois stated that social conditions, not genetics, impacted the health of Blacks, causing racial disparities in health outcomes. So this information that I'm bringing is not new. It's information we've known for quite a while. I think we're just at a point where we're really starting to discuss it in a public way to start addressing it. But again, this is something that has been known for quite a while. So how does that apply to maternal health? What do health disparities look like and why do they occur? So we have the Donovanian model for quality of care that is used for inequality outcomes. And so it says that our structures drive our process and our process drives our outcomes. The structures are the physical structural characteristics within healthcare. Processes are how we deliver care, the things that we do. And then outcome is a result of those structures and processes. I propose that we could use this same model to apply to health disparities. Thinking about structure as structural inequities that then impact our social determinants of health, healthcare disparities being the difference in how we deliver care, and then health disparities being the results of those structural inequities and healthcare disparities. And we're going to go through each of those. So thinking about structural inequities and why it's so important that we talk about this. So 80% of clinical outcomes are due to social factors. And data shows that about 50% of your health outcomes are tied to your zip code. So thinking about your physical environment, thinking about education, job status, all of those socioeconomic factors and health behaviors as well. But important for us to understand that when we're talking about health outcomes in general, we cannot talk about health outcomes and how we improve those if we're not going to also talk about social factors. Now, when we think about those social factors, these are the social determinants of health. So we have economic stability, health and healthcare access, social and the local community, education, we have the neighborhood and the built environment. And for me, I like to think about the social determinants of health as a tree because it matters where your tree is planted. Your tree is going to look very, very different if it's in the Garden District of New Orleans compared to if it's in Terrebonne Parish or if it's in Bogalusa. That looks very, very different. And so why does it look so different? And why does it look different specifically for our patients that are a racial or ethnic minority group? So there's a term that I was not familiar with called racial residential segregation. So it was a term that I was introduced to when I was at Johns Hopkins getting my master's in patient safety and healthcare quality in their public health school. So one of our first courses was in public health. And so we started talking about why certain neighborhoods are impacted in certain ways in terms of their access to resources and those structural inequities. So racial residential segregation is physical separation of the races in a residential context. So in other words, Black people live by Black people, white people live by white people, Hispanic people live by Hispanic people, Asian people live by Asian people. Some of that's by choice because we choose to live by people that look like us and have similar cultural backgrounds, but some of it is by design. So from 1934 to 1968, 98% of home loans went to white applicants. So during that time, it was very difficult to even be able to get a home or get a loan to get a home. So in 1968, the Fair Housing Act was passed to create some type of fairness in how those home loans were approved. But during an overlapping time, what ended up happening once the home loans started to be approved, then we had something called the white flight, where a lot of white families moved to the suburbs. And then Black individuals, Hispanic individuals started to concentrate in urban centers. And what happened is when the white individuals went to the suburbs, so did all the economic opportunities, so did all the jobs. And then once we had more Black and Hispanic people living in the urban centers, and you can see from 1950 to 1980, the population went from 6 million to 15 million. Now we have racial residential segregation. And this is actually then when ghettos started to form because of that racial residential segregation. And so when we look at those minority neighborhoods, and we can also look at this as an urban versus rural as well, but when we look at those minority neighborhoods, we see structural inequities. We see decreased medical and social services in those minority communities. We see targeted tobacco ads. We see higher levels of crime. We see less funding for public schools. Public schools are funded by our property tax. So when you live in a low-income neighborhood, your property tax is less, so now you have less funding for public schools. We see more food deserts. We see less green space. We see more factories. And so we see those environmental factors that then start to also affect our health outcomes, remembering that 80% of clinical outcomes are due to those social factors. One of the things that we had to do in that class was to do a 1 mile radius walk. And so I encourage each of you to consider doing this just so you can have a better understanding of where our patients are coming from. And so in the 1 mile radius walk, we're asked to go and walk in an area and then to just pay attention to the different social determinants or social drivers of health. And so I chose a neighborhood, not where I lived, but at the time I was going to a boxing gym. And so I chose that neighborhood and just started to pay attention to all of these things. So noticing that the average income, it was a mostly Black neighborhood, but the average income in the neighborhood was about $30,000, I believe it was, maybe $40,000. And then starting to look around, the closest place to get fresh fruits and fresh vegetables was a Whole Foods, which my friends and I call Whole Paycheck because it's not very affordable. But conveniently around the corner was a Burger King, there was a Rally's, there's a McDonald's right there. I saw cigarette ads for menthol cigarettes. I didn't even know that was still a thing. I saw no green space. There were no sidewalks that were not broken up. There was no safe places for crossing streets, all of those things. And so when we think about our patients and they're having to come from these environments and then come into the healthcare space, many of our patients are already behind the 8 ball before they even come into the healthcare space. And again, knowing that only 20% is due to healthcare, like the things that we're doing in healthcare, when a patient walks into my office and we can make the best plan for how her care is going to go, she still has to go back into that environment and then is exposed to all of these social drivers of health where there are inequities. And so other ways that we see lead into social determinants of health that are beyond the structural things, now thinking about those healthcare disparities. I just want to bring this up. This was published in 2003. Okay, so we're talking about over 20 years ago. Congress requested that the Institute of Medicine assess the extent of racial and ethnic disparities in healthcare, assuming that access-related factors such as insurance status and the ability to pay for care are the same. So if all that was the same, okay, and also identifying potential sources of those disparities and then suggesting interventions and strategies. And so what the Institute of Medicine found And they published this in 2003. There was a brief that was published in March of 2002, but the actual whole report was published in 2003. What they found is that even among the better control studies, the vast majority of published research indicates that minorities are less likely than whites to receive needed services. So remember, we have adjusted for access-related factors, and their conclusion was that, again, minorities are less likely than whites to receive needed services, including clinically necessary procedures, even after correcting for access-related factors such as insurance status. And so what we find, and a lot of this came from that study, is that Black individuals are less likely to be offered preventive services such as cancer screening, the flu vaccine. Black individuals are less likely to have adequate treatment of pain. Black and Hispanic individuals are less likely to receive bypass surgery, even when medically indicated. And then women, we are less likely to undergo appropriate cardiovascular testing, to be offered that appropriate cardiovascular testing. And so if we understand and we know that those preventive services are to be offered at a certain age, or the flu vaccine at a certain time of year, why is it that we don't offer it to everyone else? And again, this is the finding of the Institute of Medicine. I would say it's because of implicit bias. It's because of our biases. So our biases are unconscious. So this is not something we're doing intentionally. And our unconscious bias is defined as the attitudes or stereotypes that affect our understanding, actions, and our decisions in an unconscious manner. So again, it's unconscious, so it's not something we're doing intentionally, but that also makes it that more pervasive because it is unconscious. Just to explain how unconscious bias works. So we're gonna have a moment of reflection. If you know the answer, please feel free to put it in the chat. If you've heard me speak about this before, then you may also know the answer. And I think I can see the chat. So a boy and his father are driving down the road and they get into a car accident. The father is killed and the boy is taken to the hospital. It's determined that the boy needs surgery. The surgeon comes out and the surgeon says, "I cannot operate on him. He is my son." And so the question is, who is the surgeon? And so I'll give y'all a minute to think about that. Okay, mom is the doc. Yep. Okay. Oh, the boy's mother. Okay, I see a couple different responses. Mother. Okay. All right. Mom or grandparent. Okay. Okay, good. So the response I gave when I first heard this response, when I heard this scenario, the answer that I gave was also just not judgmental. I was like, people should be, oh my gosh, they're so biased. They just don't understand. There are all type of parental relationships, and clearly he had two fathers. Now that's not to say that he could not have two fathers, okay? But it did not even occur to me that the surgeon would be a woman. And how shameful of me, because as I've mentioned or was mentioned in my bio, I operate every single Tuesday because I take care of patients that have fibroids. I am a female surgeon, but it did not occur to me that the surgeon could be or would be a woman. So why is that? So our brains are inundated with all of this information coming in at one time, and we cannot possibly process all of this information. And so our brain takes shortcuts, and it makes these shortcuts based on our social conditioning and patterns that we formed because of that social conditioning. So for me, I never saw a female surgeon until I was in medical school. Well, by that time, my brain had already formed this pattern that a surgeon is a man, because that's probably what I saw on television, because I didn't even see I never had been to a surgeon. I'd only seen surgeons on television and they were all men. So my social, conditioning was that surgeons were men. So when I heard this scenario, my brain took the shortcut that surgeon has to be a man. And then I created a whole scenario around how to make that surgeon be a man. And so again, it's not to say that there's something wrong with me or that there's something bad about me. We all have biases because our brains all do this. I mean, initially it was supposed to be something protective. If I'm in the forest and I hear a roar, I don't need to sit around and figure out where the roar is coming from. I need to start running. So I need to have that pattern that if you hear a roar, you run. And so it's something that all of our brains do. It's not that it's something bad, but it can be bad in healthcare if we use those biases to inform our decisions about how we deliver care. So just to give you a real example of like how this happens in healthcare. So Dr. Marion Sims was known as the father of modern gynecology. He invented the speculum that we use when we're doing pap smears. He invented the procedure that repairs vesico-vaginal fistulas. He did all of this, though, by operating on slave girls. 3 of that we know in particular are Narca, Betsy, and Lucy. Narca, we know that he operated on her over 30 times over a 5-year period. He did all these surgeries, though, on these 3 slave girls with no anesthesia, even though anesthesia was available. And so what became the biased view is that Betsy, Lucy, and Anarcha and slave women had medical super bodies because they could tolerate surgery without anesthesia. So that was the biased belief. So fast forward to 2016, this was a study done at UVA. They asked 222 white medical students and residents to give their ratings about Black people and their perception about pain, and are they biologically different. So over 50% believe that Black people feel pain differently because they believe that we have thicker skin and we have different nerve endings, which is not true. Just let me make it clear, race is a social construct. It's not a biological condition. Remember, W.E.B. Du Bois taught us that. Our skin is the same, our nerve endings are the same. But the greater that those students believe that, the less likely they were to prescribe appropriate pain medicine. And so that's how biased beliefs become or start to impact how we practice medicine and how we then don't have the same quality of care for all individuals. Here's another study, and this was amongst undergraduate students asking them about their biased beliefs about Black women. So they said that they believed that Black women compared to white women were more likely to have multiple sexual partners, less likely to use birth control, more likely to receive public assistance, have less education, earn less income, less likely to follow the doctor's instructions, and less likely for the father of the child to be involved. Again, beliefs that have come about by social conditioning because this is how Black women have been portrayed throughout time. We're not going through it today, but there are different archetypes that have been used to describe Black women throughout history, throughout time in the United States. And a lot of these beliefs come out of those archetypes. And again, that then starts to affect how we think and feel about Black women. And I'm using Black women as an example, but we could very easily change this to Hispanic women, to Asian women, to any racial minority, and talk about what those beliefs are and how it impacts how we provide care to those patients. The other way that we see this come out is in microaggression. So a microaggression is a comment or an action that subtly, often unconsciously or unintentionally expresses a prejudiced attitude toward a member of a racial, of a marginalized group, such as a racial or an ethnic minority or a gender minority. And so we have 3 types of microaggressions. The first one is microassaults. This is something that we are intentionally doing because of a bias that we may have. I'll give you an example from life that doesn't have anything to do with medicine. My husband and I were in Italy. And as much as people think I'm fancy, my husband is really the one that's fancy. He wanted some Italian suit, some like handmade Italian suit or whatever. So we're in the store in Italy. And I was kind of behind him, and I noticed the store clerk was like right on his heels. Didn't ask him if he needed help, didn't ask if he could show him anything, didn't say anything to him, was just completely following him around the store. And I realized the store clerk was doing an intentional action of following him because he had a bias that he was going to steal. Same thing happened to Oprah when she was in Paris at the Hermes store. They didn't realize it was Oprah. They just thought it was another Black woman. And they refused to actually allow her to see a purse that she was asking to see. So that's a micro assault. A micro insult is a verbal and nonverbal communication that subtly conveys rudeness and insensitivity that is demeaning to a person's race, ethnicity, or gender. One that I have heard before is that, oh, you're so articulate, you don't sound Black. And so that's to say, and I will say, that's not just something I've heard from people that didn't look like me. I've heard other Black people tell me that. And so that means that you have a bias that there's a certain way that Black people are supposed to sound. And so that is a micro insult and basically insensitive and rude to say, to make that assumption about my race. And then a micro invalidation is a communication that subtly excludes, negates, or nullifies the thoughts, feelings, or experience reality of an individual. So an example of that, a few years ago, we were saying stop Asian hate. And there was a time again that many people were saying that, but other people were responding with stop all hate. Well, of course, we want all hate to stop, but at a time when my Asian friends were afraid for their grandmothers and grandfathers to walk down the street because they didn't know if they were going to get attacked, that would be very insensitive to not acknowledge what they were experiencing in that moment. And the issue with this in the healthcare setting is that we don't walk into the door and all of a sudden stop our biases or all of a sudden stop our microaggressions. We use these every day in the way that we interact with each other and the way that we interact with our patients, particularly those patients that come from a lower socioeconomic status. And so we have to think about that. The other way we see this is how we document in the chart. This was a study that was done by JAMA where they identified there's 5 major things that they can see in the medical record. Questioning the patient's credibility. When we put things in quotation marks, expressing disapproval of patient reasoning or self-care, stereotyping by race or social class, portraying the patient as difficult. When we say a patient is difficult, when we say that patient is non-compliant, we've now stereotyped them for everybody else that's going to pick up that chart. When we didn't take the time to even ask questions to understand they may have barriers for why they cannot be compliant. And so now we have again used that microaggression. And also emphasizing the physician authority over the patient. And then we have to remember our patients can see our medical records now. So when they see that, then that begins to create mistrust and distrust of the healthcare system. Especially again, we're talking about those patients that have been already impacted by those structural inequities. And so when we combine those social determinants of health that are impacted by structural inequities, healthcare disparities, then together we have health disparities. So what do we see in our health disparities in terms of maternal child health? So we know that nationally, Black women are almost 4 times more likely to suffer a pregnancy-related death compared to white women. In fact, in February of this year, the CDC released its most recent maternal mortality report. It was data from 2023. We actually saw a decrease in maternal mortality from 2022 to 2023, which is great. Still not as low as it was in 2018. So questioning if we're going in the right direction. But even with seeing that statistically significant decrease from 2022 to 2023, the rates went down for every single race except for Black women. Our rates actually went up. And so we're seeing, even with improvement, the disparity gap may be getting even wider. And again, we have to think about structural inequities, social determinants of health, and then how are we responding in the healthcare system. Also, the rate of preterm birth among Black women is 50% higher than that of white women. Understanding that in the United States, we have a grade D from the March of Dimes for our preterm birth rate. In Louisiana, we have a grade F. And so for our Black mothers, our Black infants, they're even more disproportionately impacted. The infant mortality rate for Black infants is twice that of their white infant counterparts. And then the reason that we can say these outcomes are due not only from social determinants of health, as W.E.B. Du Bois told us, but also from differences in how care is delivered, that everybody's not getting high quality care, as the Institute of Medicine told us, is then looking at this data. A Black woman with a college degree is twice as likely with a white woman with an 8th grade education to experience a pregnancy-related death. So in thinking about all those things, which can be very daunting, is there a pathway for change? What can we do different? The answer is yes, there is definitely a pathway for change. The first thing that I would say is that you cannot have quality without equity. We cannot improve outcomes for everybody if we're not looking to see who has the worst outcomes and then working to improve their outcomes. So when we think about that, the Institute of Medicine, several years ago, came up with a definition of quality. They said quality is the degree to which health services for individuals and populations increase the likelihood of a desired health outcome and are consistent with current professional knowledge, meaning evidence-based practices are done, and that will increase the likelihood of a desired outcome. They said to do that, we have a couple of domains. Care has to be safe, it has to be effective, it has to be patient-centered, it has to be timely, it has to be efficient. They came back later and they said, we're missing a domain. And they came back and said it has to be equitable. Then they came back and said, actually, equity has to be woven into all of these. We can't have safe care if it's not equitable care. We can't have effective care if it's not equitable care. We can't have patient-centered care if it's not equitable care. And the way that we know if we are getting to this definition of clinical outcomes is looking at health disparities. And so I've just explained where our disparities are. So we have a long way to go to making sure that everybody is able to have desired health outcomes. The word equity for sure has been misunderstood and mistaken as to what that means. I love this picture because I think it helps us to understand really clearly when we're talking about health equity, what we mean. So if you look on the left, you can see an example of equality. Everybody is getting the same resource. Regardless of need, everybody gets the same resource. And you can see their outcome is that they're trying to see this baseball game and the fence is in the way. The fence is the barrier. For the first guy, he didn't even need the resource. So he didn't even need that. The second guy, that resource was exactly what he needed. The third guy got the same resource, but he still can't get to that outcome. When we're talking about structural inequities and trying to address those, what we're talking about is meeting people where they are to give them the resource that they need. So this first guy, again, he didn't need a resource, great. Second guy, he needed that resource, now he can see it with the fence. The third guy got the resource that he needed. We met him where he was to get to that outcome of seeing the fence. Of seeing the baseball game over the fence. So for our patients, what we should be doing is screening for social determinants of health, understanding where they are coming from, what their barriers are, and helping them to navigate and getting them the resources. So again, everybody can have that same outcome. To give you a real life example, or to give you, kind of a real life example. Okay. So we know that from our information from ACOG, Society of Maternal Fetal Medicine, from the Alliance for Innovation on Maternal Health, that for patients who have severe hypertension in pregnancy, that they need to have a blood pressure check within 72 hours of discharge from the hospital, okay? If I go on rounds and I give everybody give every patient that meets this criteria an appointment to see me in 3 days, that's equality. I gave everybody an appointment in 3 days. My patient that has a daytime nanny, she has somebody to watch her child, she has somebody to drive her to the clinic, she may come in for that 3-day appointment. My patient that has no paid family medical leave is trying to figure out how she's going to get back to work, doesn't have transportation, doesn't have childcare, and lives a long distance, she probably is not going to come for that appointment because because of the number of barriers, those social inequities that we talked about, those barriers. And then what happens in the healthcare system is that we then label that patient as non-compliant. When in fact, what I should have done is at the beginning of their pregnancies, I should have done a social determinants of health screen to understand that second patient had those barriers and then come up with a different way of providing that visit. Maybe I send that patient home with a blood pressure cuff and we set up a virtual visit. Maybe I arrange for that patient to have a home visiting nurse come in her home and check her blood pressure and check for symptoms. Maybe I have that patient have a doula as part of her care that can come in and check that blood pressure. And so that's just the example of where we're trying to go for making sure everybody can have that optimal outcome and we can address those structural inequities. So looking from big picture to little picture, how do we do this as well? because that's an individual thing. For us, from a public health standpoint, we have to think about broader solutions, so that we're not putting out little forest fires, that we have a solution for everybody. And part of that, you'll see that the big things for these social determinants of health are going to be things that we have to do from a public policy standpoint. But even from a healthcare system, there is not as big of an impact you can see in this framework from the World Health Organization, but there are things that we can do. And I just gave you one example. But just understanding from a public health standpoint is going to take more public policy changes. One that we've seen that has been a great policy change is the extension to Medicaid to 1 year postpartum. We know from our mortality data that the majority of deaths are not happening at delivery. They're happening after delivery up to 1 year postpartum, with the majority happening in the first 6 weeks if we think about just pregnancy-related deaths. So by ensuring that Medicaid is extended to 1 year, that's one tool to make sure patients have access to care. And so again, addressing one of those structural inequities. In the healthcare system, in the hospital, we have a framework that comes from the Institute of Healthcare Improvement, and that's making this a strategic priority, developing structures and processes to support the work, deploying strategies to address these structural inequities that we can do as an organization. Also seeing where do we have institutional racism within our organization? How are we making it more difficult or making it easier for different patients with different barriers, physical barriers, as well as social barriers, to be able to access care. And then developing partnerships with community-based organizations. I think this one is so key. When we think about those social determinants of health, we don't have all the answers, especially in a hospital or a healthcare space, but there are a lot of community-based organizations with resources. They have the resources, but they can't identify the patients that need the resource. We are in the hospital, we've identified the patients that need the resource, but we don't have any resources for them. And so it really is us working together to make sure that our patients have the resources that they need, that are out there. And then thinking about it from how we address this from a quality standpoint, this is the roadmap to reduce disparities. It comes from the Robert Wood Johnson Foundation. They have actually created another roadmap, or they've updated this to advance in health equity. But I like the old roadmap better, so I still use this one. When we're talking about reducing disparities, we have to link quality to equity, which we've done today, creating a culture of equity, diagnosing the disparity. So screening for social determinants of health. When we look at our data, looking at structure, process, and outcome, disaggregating that data by race, ethnicity, language, insurance type, where people live, all of those things, to understand where do we have a difference in our outcomes, but also where do we have a difference in our processes, in the way we're delivering care. Is everybody getting the same quality of care? Once we see where that's not happening, then diagnosing that, designing an activity to address that, getting buy-in for leadership, and then implementing that change. And then for each of you as individuals, understanding how you may be also making the problem worse because of your bias. And so part of that is understanding where you have biases, understanding that biases are unconscious, they're like habits. And so you have to work at it intentionally every single day to change your bias and to turn it around. When you're tired, when you're hungry, when all those things, you tend to then, even when you're working on your bias, you tend to go back into old habits. So you also have to have self-care as part of that. Patricia Devine is a social psychologist that has shown that you can turn your bias around if you work intentionally at doing so. Part of that is seeing people as individuals, recognizing if you have a belief, is that belief a stereotype? So is that person really doing those things, or is that a stereotype that you've assigned to them because of a bias? Increasing opportunities to have contact with individuals from different groups. And then most of all, especially for all of us in healthcare, empathy, putting yourself in someone else's shoes. When you have patients that come in and they're late for their appointment, do you ever ask why? I will never forget, this is when I was on the Committee on Healthcare for Underserved Women for ACOG. This is back in 2010, I think it was. It may have been 2011. And our chair of the committee was just explaining, he lives in the northern part of the US. He had a patient that was late, and he was so frustrated because so many patients had been late. And he finally asked her, why are you late? Why are you so late for this appointment? And she said, I'm so very sorry. We don't have running water. I have to collect snow. I have to melt the snow to be able to take a bath or take a shower to come in to be clean. And it took me a lot longer than I thought that it was going to take. And that's why I'm late. And he was boohoo crying and felt so very small. A lot of times we don't understand the barriers because of structural inequities that our patients face in just being able to come in for a visit. I don't know what it's like to ride the bus. That's my privilege. I've always had transportation, but that is a privilege that all patients don't have. And so we have to be empathetic to understand where our patients are coming from before we start to label them as non-compliant or that they just don't care, or we label them as difficult. And so I will, actually, I'm gonna go back to this quote. So in summary, the causes of health disparities are complex in nature, definitely structural inequities, as well as bias, that can all be a part of these outcomes, but there is a pathway to improvement. And then I'm going to leave you with this quote, and this is from Dr. Martin Luther King Jr. He says, "Of all forms of inequality, injustice in health is the most shocking and the most inhumane." And then I have a video, but I am going to hold off showing the video so that I can take the time to answer questions in case there are questions. If we have extra time, then I'll see if I can get the video to play. And then I'm happy to answer any questions that you may have.
Thank you for that amazing presentation. I learned a lot, and a lot of it was, great stuff that I also learned from my public health classes back when I was in grad school. So I'm gonna go ahead and start fielding some questions. Does anyone have any questions, to ask? So, someone asked, are we able to receive the slides? Yes, it will be sent, in an email later.
And then Michelle asked if I can recommend a social determinants of health screen. Sure, I'll put it in the, let me see if I can't talk and type at the same time, but I'll put it in the chat. I think what's important, this is one of the things that we're working on with our birthing facilities through the LAPQC. It's the screen is important, like which screen you use is important, but probably more important than that is how you do the screen. So part of that is scripting. So think about it. When you're screening for social determinants of health, one of the questions, for example, is food insecurity. I'm gonna tell you right now, if I came into the doctor's office and my doctor said, "Are you having trouble getting food?" I'm not gonna say yes, even if I am having trouble. What are you supposed to do? You're a doctor. Well, how are you gonna, how can you even relate to what that's like? How are you going to help me get food? So we have to think about what that scripting is, making sure our patients understand why we are asking the question, but also doing resource mapping so that when they say yes, we have resources. I think that one of the things that holds us back from screening for social determinants of health as healthcare systems, as healthcare providers, is just when someone says yes, what are we going to do? How are we going to help them? And so if you do the resource mapping, that is one way. I'm sorry, I'm giving y'all the information from the AFFP. This is, I think, this is one of the good resources. I'll put it in the chat so everybody can see it. And so again, one of the things that can be done is that resource mapping, especially to do that with if you've not had this before, but a patient partner as part of your quality improvement team, someone from the community that can help you identify those resources. So again, that you're able to then have a response when that patient says yes. For those of y'all who don't know, if you work in the hospital system, CMS and Leapfrog are now requiring that we have patient partners as part of our quality improvement team, and they can give us so much information and so much insight to what patients really, really need.
Thank you for your answer. We have another question that asks, as a researcher, I find these data are sobering statistics of inequities of maternal health. What do you advise as ways that researchers can work with advocates in this space to bring more awareness? Is it through communication of people's stories and lived experiences rather than just numerical data? Is it by focusing our evaluations on equity from the very beginning when we are thinking about how research is conducted and data are analyzed?
So Jordan, that is an amazing, amazing question. The answer is yes to all of it. One of the things that I always get pushback on when I'm presenting this type of and clearly I have data. I got a whole thing of references that y'all will see, and I've mentioned some of them as we present it. But one of the pushbacks I always get is, what is the data? What is the data? Well, where are you getting that from? Well, where did they study that? Well, how do I know if that's really true? And so as a researcher, to be able to continue to bring that data, like that's a great study that they did at UVA, just asking that question about bias around Black people in pain, and seeing how that impacted how they were actually prescribing pain medicine. So thinking about those things and researching that, and then publicizing that research, I think is amazing. When we're talking about change, and I'm happy to come back and do a lecture on this too, but I do a lot with change management, obviously, in my role of quality improvement. You always want to speak to the head and you want to speak to the heart. So it's not one or the other. You want the people's stories because that's speaking to the heart. That's what engages people and makes them want to lean in a little bit more and listen. But people also want to be spoken to as the head, especially in the medical field. Like, stories are anecdotal. They need the data, but you need the stories to bring people in. So it is really the two together, as a researcher, where you're able to bring that change. And then it is thinking about looking through a lens of equity when you are designing your research, making sure if there's a question that you're asking, are all groups represented? Part of the reason right now, not to get into too much, but from a medicine and an evidence-based medicine practice, we have extrapolated so much from research to apply to women, to apply to racial minority groups, because they're underrepresented in research. It wasn't until the 2000s, I can't remember the exact year, that the FDA required studies have a certain percentage of women in those studies. And that was because a medication came on the market. After the medication was out, it had only been tested mainly in men. The medication came on the market and they realized, well, women were dying, and because they metabolize the medicine different. And so we always want to think about making sure we have diversity in our study population as a researcher, to make sure that the findings are applicable to everybody.
We have another question that asks, how do you help people address their bias when they don't recognize it exists, or when they simply believe their bias is true for most of the population they serve?
That's also a great question, and also a question. I was in Mississippi giving a similar presentation last week, and this came up, that the physician was saying he was speaking at the Rotary Club, and the other physicians were like, I mean, well, the people on Medicaid, they don't want to work. And that is a clear biased belief, because my patients that are on Medicaid have one job, not only one job, they usually have two, because we're paying the minimum wage, which is not a living wage. So I think it's really important to just speak truth to power. We all have the ability to be a bias interrupter, which I know can be very hard to do, and can be very, you have to be very courageous to do that. But just to call people out and just say, and I'm thinking about a time this many years ago that I did not do that, and it haunts me. I think about it all the time. And when I heard a nurse say something, and I really should have in that moment said something, because she was making a bias. It wasn't a racist comment, it was a biased comment, and I should have said something. But we all have that ability, that if you are seeing that happen, to be able to say something about it. And then just speaking truth to power, and making sure you help that individual understand as a stereotype and not an actual fact.
And we have another question from Edward that says, within healthcare itself, are there movements to address technologically based bias in regards to race? For example, pulse oximeters, accuracy based on different skin colors absorbing more or less IR light, especially as AI is used more in medical recording / diagnosing, are there guidelines for computational bias of the kinds we've seen in camera tech or natural language processing not trained in AAVE?
That's a great question, Edward. And there have been many discussions about this. I think to your point around, I guess it's with the infrared light. It became known or acknowledged during COVID-19 with the pulse oximetry monitors that we use on the fingers, that how it calculated the pulse ox was not correct for people with more melanin. Then going back and understanding that when it was validated on mostly individuals that were white. And so there is more information that's coming out now. The change, that's the part. I'm not sure how much or who is leading change around that. In terms of AI, yes, I have a love-hate relationship with technology and a love-hate relationship with AI. I think it has great potential. I saw a demonstration where they were able to use AI to create avatars that look like people, not avatars like cartoons, avatars that look like people, and they were able to generate avatars that looked like the people that they were speaking to create that cultural competency and that congruency of race, which then we know from data creates trust. But we also know how AI makes decisions in the clinical decision-making space is inherently biased because AI makes those decisions based on research, based on peer-reviewed research, which you've already said is biased because it doesn't have diversity of people represented in the studies, or from the way that we practice, which is bias. Great example around that is, and I already talked about it before, is AI may be less likely, a study showed this, AI may be less likely to recommend a particular cardiovascular testing for a woman because we don't order that test for women because we, in a biased way, don't do the right diagnostic test for women. So definitely there is a lot known about the bias and the potential for more bias because of AI. I just hope that the people that are the manufacturers, the technology companies that are creating the AI technology, that they're considering that. A lot of us on the user end recognize it. I'm not sure how much on the manufacturer end they're incorporating that in. But that's a great question.
Are there any other questions that anyone in the audience would like to ask? So we have a couple minutes remaining. Dr. Gillispie-Bell, do you want to play that video that you had up?
Sure. Okay, give me just a second. I'm going to share and I'm going to optimize. Oh, it's not letting me optimize for sound. So I'm not sure y'all will be able to hear it. I don't know if that has been turned off. Yeah, I think the sharing feature is only letting me share the video, so I don't think y'all will be able to hear it. But there's a link. I can let me just try, but I don't think y'all will be able to hear it. But there is a link in the presentation if anybody wants to watch it.
Line up, everybody line up.
Are y'all able to hear that?
Yeah, we can hear that.
Everybody line up. Shoulder to shoulder. Take off your backpack. Basketball, line up. We're about to race. We are racing for $100 bill. The winner of this race will take this. $100 bill. Before I say go, I'm going to make a couple statements. If those statements apply to you, I want you to take 2 steps forward. If those statements don't apply to you, I want you to stay right where you're at. Take 2 steps forward if both of your parents are still married. Take 2 steps forward if you grew up with a father figure in the home. Take 2 steps forward if you had access to a private education. Take 2 steps forward if you had access to a free tutor growing up. Take 2 steps forward if you've never had to worry about your cell phone being shut off. Take 2 steps forward if you've never had to help mom or dad with the bills. Take 2 steps forward. If it wasn't because of your athletic ability, you don't have to pay for college. Take 2 steps forward if you never wondered where your next meal was going to come from. I want you guys up here in the front just to turn around and look. Every statement I've made has nothing to do with anything any of you have done. Has nothing to do with decisions you've made. Everything I have said has nothing to do with what you've done. We all know these people up here have a better opportunity to win this $100. Does that mean these people back here can't race? No. We would be foolish to not realize we've been given more opportunity. We don't want to recognize that we've been given a head start. But the reality is we have. Now, there's no excuse. They still got to run their race. You still got to run your race. But whoever wins this $100, I think it'd be extremely foolish of you not to utilize that and learn more about somebody else's story. Because the reality is, if this was a fair race and everybody's back on that line, I guarantee you some of these black dudes would smoke all of you. And it's only because you have this big of a head start that you're possibly going to win this race called life. That is a picture of life, ladies and gentlemen. Nothing you've done has put you in the lead that you're in right now. When I say go, on your mark, get set.
So that's just a visual depiction of what social inequities look like. And so again, when we think about that empathy part, just remember that some patients, we're all running the same race, but some people start so much further behind.
Thank you so much for your presentation and so much for the time that you have here. Thanks everyone for attending. It is a little past 1 p.m. now. I just want to remind everyone that our next Lunch and Learn is on May 15th with Dr. Allison Swift. And if you have a moment, please fill out the post survey about today's Lunch and Learn to help us gather some feedback. And if you are getting CEU credits, that is mandatory for you to get your CEU credits. Again, thank you so much. Everyone for attending. Thank you, Dr. Gillispie-Bell, for your amazing presentation. And shout out, of course, to our ASL interpreter for today. Everyone have a great day.
Thanks, everyone.